Hello everyone. Today's topic is typhoid fever. Let us start with the introduction. Typhoid fever is caused by an infection with gram-negative bacteria, Salmonella typhi or Salmonella paratyphi. It is also known as enteric fever. Why? Because these bacteria they infect the small intestine. Here comes an important point. This is a systemic illness, which means these bacteria are not only confined to the gastrointestinal tract or the small intestine, but they spread throughout the body, causing symptoms like fever and abdominal pain. So, although we call it as enteric fever, but it does not mean that these bacteria are confined to only small intestine, but they spread throughout the body. Risk factors. Children and young adults are at a higher risk. Poor sanitation and overcrowding are another risk factors for this infection. Mode of transmission. Fecal-oral route, contaminated food are common modes of transmission. Food contaminated with the feces of a person carrying Salmonella typhi transmits this infection to healthy individuals. Direct person to person contact. Humans act as reservoirs for this bacteria. A person who is infected with Salmonella typhi or who is just the carrier of this bacteria transmits this infection to a healthy individual just by handshake. So, direct person to person transmission is very common. Incubation period is 10 to 14 days. This is the time period from the entry of bacteria into the body till the appearance of symptoms. So, this is 10 to 14 days. Pathogenesis. Now, for this infection, for these bacteria, large number of organisms are required for this fever to take place, unlike Shigella infection where a small number of organisms are enough to cause the infection. Here oral uptake of large number of bacteria is required to cause this infection. These bacteria they then enter the distal ileum, the Peyer's patches. Here, they proliferate in the M cells or the macrophages of Peyer's patches. From the macrophages of the Peyer's patches, these bacteria they enter the entire bloodstream. After that, they reside in the liver, in the spleen, gallbladder, causing primary bacteremia. Again, these bacteria they leave the organs and enter the bloodstream, causing sepsis, septicemia, and secondary bacteremia. So, in this way, these bacteria are spread throughout the body and not just confined to the small intestine. So, from pathogenesis, it is also clear that this is a systemic illness. Clinical presentation. So, clinical presentation this is seen in three phases according to the weeks of infection. Week 1, temperature rises gradually. What happens in week 1 is temperature rises gradually, slowly. Relative bradycardia is the most important feature of typhoid fever. Normally, what happens in normal fever, for every 1 degree rise in temperature, the pulse increases by 10 beats per minute. I am repeating again, for every 1 degree rise in temperature, pulse increases by 10 beats per minute. But this is not so in case of typhoid fever. In case of typhoid fever, relative bradycardia is seen in week 1, which means whenever the temperature rises by 1 degree, there is no rise in the pulse. This is known as relative bradycardia and it is a characteristic feature of typhoid fever. Constipation and diarrhea is also present. Pea soup diarrhea, they both occur at equal frequency. Headache is also present in patients. What happens in week 2 is persistent fever or what we call as stepladder fever. What happens in stepladder fever is, for example, on day 1, fever rises gradually throughout the day from morning till the evening, but on the next day, there comes a plateau. Temperature becomes constant, patient feels relieved, but on day 3, again the fever rises, the temperature rises gradually from the morning till the evening. So, this occurs in a step ladder fashion, in a step ladder manner. Persistent fever happens in a step ladder manner. Rose spots are also seen around the navel or the lower abdomen, red colored spots. Coated tongue or typhoid tongue is also present. Yellow green diarrhea or constipation. Delirium or coma is also seen. Delirium or coma happens when this bacteria enters the blood brain barrier. These bacteria, Salmonella typhi, can easily cross blood brain barrier, thereby causing delirium or coma in patients. Now, what happens in week 3? Clinical features of week 2 are present, and along with that, gastrointestinal ulceration, Peyer's patches perforation. Now, why this is present? We already saw in the pathogenesis that these bacteria, they proliferate in the M cells, in the macrophages of Peyer's patches, thereby causing the Peyer's patches perforation in case of severe typhoid. Hepatosplenomegaly is also present. In rare cases, meningitis can also be seen. Why meningitis? Because these bacteria can cross blood-brain barrier, thereby causing meningitis in severe cases. So this is the clinical presentation. So here is a picture depicting the rose spots which are present in the second week of infection. They are present around navel and lower abdomen. Next comes the diagnosis of typhoid fever. There are 4 ways. First is the blood culture. It is the most important diagnostic tool. It can be done as early as possible and it is the most accurate one as well, blood cultures. Then is the stool cultures. Stool culture is considered to be of low yield because it is often negative despite active infection. Stool culture comes positive after 2 weeks of infection. So these are considered as low yield. Next is the bone marrow culture. Bone marrow culture is the most sensitive modality. It means it is the most accurate amongst all, but still it is rarely performed as it is a very, very invasive procedure. So it is, despite being the most sensitive modality, it is not done. Next is the Vidal test or serology. Serology is where we detect the antibodies formed in the body against the bacteria, formed in the blood against the bacteria. Vidal test is also not recommended nowadays because this test is positive due to previous resolved infections. If a patient had typhoid, he got treated, he got proper medical care. Still, when we perform Vidal test after few months, that test comes positive even after proper treatment. So it is not accurate. It is less sensitive and less specific. So amongst all, blood cultures are the most accurate ones. Next is the treatment. So for treatment, quinolones are the most important ones. Normally, there are many strains of salmonella which become resistant to quinolones, but still there are many strains of salmonella which are sensitive to quinolones, so we can use quinolones. For example, tab ciprofloxacin 500 mg BD per orally for 10 days, tab ofloxacin 400 mg per orally BD for 10 days, tab cefixime, which is a third generation cephalosporin, 200 mg BD per orally for 10 to 14 days can be used. If bacteria becomes resistant to quinolones, azithromycin comes into play. We can use azithromycin 10 to 20 mg per kg of body weight per day with a maximum dose of 1000 milligrams per day. Now, in case of severe typhoid, which presents symptoms like impaired consciousness, a state of coma, organ dysfunction, because in severe typhoid, bacteria is able to cross the blood-brain barrier. So in these cases, injections are given. The antibiotics are given intravenously. For example, injection ceftriaxone 2 to 3 grams IV OD for 10 days. Injection cefotaxime 2 grams IV OD for 10 to 14 days. In case of CNS involvement, steroids are of great help. For example, injection dexamethasone can be given. Steroids are given as they are known to increase the mortality rate in patients with severe typhoid. Next are the complications. The most common complication is chronic salmonella carriers. Now, what happens is when bacteria enters the body, when salmonella typhi enters the body, it proliferates, causes acute infection. And if acute infection is not treated, eventually after third week, the symptoms resolve spontaneously. But still, it does not mean that salmonella has gone. Salmonella still hides within the organs, especially in the gallbladder of the patient. The person becomes chronic carrier even if the person is asymptomatic, but still he or she becomes the chronic carrier and can spread typhoid to others. He is not seeking medical care and asymptomatic, so becomes chronic salmonella carrier and shows positive stool cultures 12 months after overcoming the disease. Salmonella typhi itself colonizes the gallbladder and can cause gallbladder cancer, but the patient is asymptomatic. So these chronic salmonella carriers can be treated by giving ciprofloxacin 500 mg BD for 6 weeks. A very classic example of typhoid carrier, chronic typhoid carrier or salmonella carrier is typhoid Mary. She was a cook and she was a chronic salmonella carrier and spread those bacteria to different individuals, to healthy individuals via the food she cooked. Other complications are intestinal perforation, meningitis, delirium. Again, meningitis and delirium are seen when these bacteria they cross the blood-brain barrier. Myocarditis, pancreatitis and hemorrhage are another complications. Now is the prevention. Typhoid fever can be prevented by the use of vaccination along with food and water safety. Vaccination alone cannot confer lifelong immunity, so along with vaccination, food and water safety are very important. Different types of vaccination like attenuated bacteria, that is weakened bacteria in the form of capsules, are given to the patients, but vaccination is not that much important. Along with vaccination, food and water safety, and in fact we can say food and water safety are more important than vaccine, because only vaccine cannot confer lifelong immunity against typhoid infection. So thank you so much. If you still have any doubts, please let me know in the comment section.